So when you started your work as a medical oncologist, and you've been doing lung cancer a long time, the shift from where you began in understanding the disease to where we are now is pretty dramatic.
Oh, it's amazing.
When you began, what was your understanding, you and your colleagues, if you go back 30 years?
Sure.
How did you understand lung cancer 30 years ago?
You know, I had a leadership role in the Eastern Cooperative Oncology Group. I ran the lung cancer committee in the 80s. And it was a strictly empiric, you have a drug that is cytotoxic, try it out in lung cancer. And we ran multiple studies that unfortunately were negative. And they were based purely on the observation that a type of drug, perhaps an analog, a different chemical structure, a slightly different mechanism of action, worked in certain laboratory systems. Let's try it in people with lung cancer. And there were very few drugs that came out of that. So through the 70s and 80s, it was empiric. Even through the 90s.
Really poor survival.
Oh, terrible. And then came a total shift from empiric, take it off the shelf, try it, to beginning to understand what we now call targeted treatment. And that is, if you picture the cancer cell and the cells around it as having circuits. And there are certain points in that circuit that get turned on and get turned off. And we now have begun to identify them. Example, epidermal growth factor receptor is one of those circuits. And so it's a particular target.
Is there more you want to share on the therapeutic front?
Yes. So what do I do with a patient with lung cancer who comes to me when I go back to my office? So one of the issues is maintenance. So the idea is that chemotherapy is much better than it used to be. We've got a number of drugs. Remember, I sort of stopped the clock in the 90s. So there are a number of drugs for lung cancer that were not available in the beginning of the 90s. Gemcitabine is one, pemetrexed is another, different taxanes. So these became clearly available and useful. So the question is then, given more drugs, at what point, once you've started a person on treatment, there's a response to treatment, or at least no progression of disease, which is a meaningful objective. Do you continue the drugs in the face of some benefit, increasing side effects, accumulating chronic toxicity? Do you continue the drugs, or do you stop and give best supportive care and look at the so-called symptom-free interval? So that's been a very important question. There are a number of clinical trials. It presented last year, actually 2 years ago, for adenocarcinoma of the non-small cell type. Clearly, pemetrexed is of benefit, Alimta, compared to not continuing. But it's more complicated than that. And so what we now know is that a very interesting study that, again, that was just presented is a study of chemotherapy. And then the question is, do you introduce a new drug? So it was a platinol plus a taxane. And those patients who either had a response or stable were randomly combination chemo, exactly, were assigned at random as part of a clinical subject, either to receive a new drug, gemcitabine, or best supportive care, go through a progression, a symptom-free interval, and unfortunately, with advanced lung disease, their tumor does start to grow. At the point of progression, then they all got pemetrexed. And the outcome was those patients that got gemcitabine, rather than best supportive care, did better. But there are some studies that were presented in other settings, example, starting out with a combination of platinum, gemcitabine, get gemcitabine, or best supportive care to the point of progression. There was not a difference there. So that the pemetrexed observation of maintenance is proven, but adding gemcitabine, it's drug specific, not a general phenomenon. So maintenance remains an important issue, and one that is continuing to be studied and has to be individualized.